Good morning, everybody. We'll start in just a few minutes. Look at that, 5 minutes to spare. All that panicking over the time.
Oh my gosh. Just getting it from one computer to the other, Josie. That was it. Wouldn't think it would be that hard.
It's only Wednesday.
Monday night I fell asleep. I was sitting at home like, wait a second.
Mm-hmm.
Is it the same thing?
Leadership one is just one that I presented.
Don't they have a day the conference? Is that what? Yes, okay. We had some people that went last year and it was amazing. Yeah.
And then next Friday,
for Boston.
Yeah, that one's great. That was great.
Our conference.
Yeah, this room was really kind of dull for a long time, so we had to, we painted, we added artwork. Because we spent so much time. One time I bought here for a meeting, and they were doing it on the phone only. Okay, should we get started? 11 o'clock? Hey, good morning, everyone. My name is Josie McPherson. I am the Senior Director of System Advocacy here at NISCASA. Welcome to our webinar, The Role of Advocates Within the Forensic Exam Process. I'm going to turn the call right over to Nancy Harris and Lindsey Crusan-Muse. And if you have any issues, please email me at jmcpherson@NISCASA. That's JMCPHERSON at NYSCASA, NYSCASA.org. And I'll hand over the call. All right. If you have any issues with hearing us, please type your message into the chat box. Okay, go right on.
Okay, good morning.
Good morning, everyone.
This is Nancy Harris. A little bit about myself. I'm a nurse practitioner. I work for St. Peter's Health Partners, the manager for their forensic nursing program. We cover hospitals in Albany and Troy. We also cover 10 child advocacy centers throughout New York State. And I am also the Director of Operations for United Concierge Medicine Telophase program, where we have a 3-year grant and are covering rural locations that need sane assistance.
Hi, everyone. I'm Lindsey Crusan-Muse, and I'm very privileged to work alongside Nancy at St. Peter's Health Partners. I'm the Director of the Sexual Assault and Crime Victims Assistance Program there. And our department is focused on providing advocacy and counseling to survivors of sexual assault and really all crimes. Our main office is in Troy, New York, which is part of the Capital Region, and we are the Certified Rape Crisis Program serving Rensselaer County. And I'll talk a little bit more about our services a little bit later on, but we're going to start off with hearing from Nancy.
All right. All right. So today we really just want to talk with you about what the forensic exam process looks like. And then I know that Lindsey will, definitely talk with you about the advocates, their responses and roles, and then definitely want to give you plenty of time for questions. So we want to let you know that the forensic exam process can look different every single time. I have so many nurses that will say to me, well, I did a couple of exams and I don't really know if I'm ready to come off orientation because I haven't, they haven't been the same. And I always want them to know that the exam is always going to look different. It's really up to what the patient wants, and the patient chooses what that exam is going to look like. When a patient presents to the emergency room, they usually will walk in. They can come in via ambulance or with law enforcement. They're greeted at registration, given a chief complaint, and basically that chief complaint is what brings you into the hospital today. So once that patient says that they are there for sexual assault or they've been raped, what will happen is a call will get put out to our SANE nurse and to the advocate. The patient's seen in triage. They usually have some vital signs and a brief history, basically, of what's going on. They will then take the patient to a private room, and that's where we will meet up with the patient. According to the Department of Health, we actually have 60 minutes to arrive. I do have some nurses that live a good 30, 40 minutes away from the hospital, so they are normally ready to go as soon as a call gets put out. One of the most important things for the exam is to obtain consent. The patient needs to give consent to us for medical exam, consent for photos, consent for evidence collection, and it's different for the drug facilitated and the evidence kits. We want a consent to treat. We want a consent to gather any cultures or any tests. And we also need a consent to release information. We ask separately, do you want this released to law enforcement? Do you want it released to a child advocacy center, district attorneys, CPS? And we also ask if they are a college student, if they do want us to be able to speak to the colleges. One of the first things that we do once we're with the patient after we get consent is the medical history. we want to know more about this patient. We want to know any medications, any allergies, any recent illnesses or diagnoses, any hospitalizations. We also want to talk with them about last menstrual period, any pregnancies, and most important is to ask them about last sexual intercourse. The reason that we need to ask this question is because if we are gathering an evidence kit and sending it off to the crime lab, we need to know if there's a possibility of another DNA that might be in there. So we always want to ask that question for the patient. The assault history is usually when it gets to be a little more difficult for the patient. We usually see a change in their demeanor when we really start to ask about the assault history. So what I try to do to make it easier for the patient is I say to them, just give me a brief description of what happened, because I am going to go into a more detailed question. Sometimes it's difficult for that patient to remember everything that happened word for word, and I don't want them to feel that they have to. We always want the patient to know that we're going at their pace. If they need to take a break, we're going to take a break. When we get into the detailed questions, it's more of was there any contact to the vagina? And then we're going to ask them with a penis, with fingers, any oral, with the mouth. And all they have to do is say yes or no to those questions. And that does give them time to think about what had happened. And at that point, they may give us a little bit more description, and that's perfectly fine. We always need to explain to the patient why we're asking these questions. And I want them to know, this is why we're asking. We're asking because we need to know where are we going to go to look for evidence, where are we going to look for any injuries, and we want to make sure that they are medically okay. Our physical exam is going to be a head-to-toe. We do this on every patient. We want to look at the patient with their clothes on, with their clothes off. We're going to be touching them from head to toe for any tenderness, areas that we need to collect evidence or photographs. And sometimes when we do touch the patient, it reminds them of something. I had one patient one time when I was just touching the back of her head, and when I did, she said to me, "Oh, that's right, he pulled me by the hair." So that is one of the other reasons, too, that we want to make sure we have hands-on and we're touching the patient. And again, reminding the patient that we are touching them. I always let a patient know, even if I'm taking a blood pressure, I always say to them, I'm going to put the blood pressure cuff on, it's going to get tight. I want the patient to know that we're going to touch them and ask for their permission. The evidence collection kit has 15 steps. I always laugh and say, I think I could do this in my sleep sometimes. But it's very detailed, and it really is driven by what information was given to us by the patient. So oral swabs and smears are going to be collected if there was oral contact, because we're looking for the perpetrator's DNA. Buccal swabs are going to be the patient's DNA. Any trace evidence. When we have the patient undress, we have them undress actually in front of us, and we take each item of clothing and put them into separate bags. We have them stand on a piece of paper that afterwards we will pick up and put into the evidence collection kit for any debris that might fall off of their clothing. So we are collecting their clothing, we are collecting their underwear. Even if the patient has taken a shower, we want to make sure that we are still taking the underwear. Any debris that's on the patient is another envelope that is in our kit. We have bite marks or dried secretions and swabs. So if we are doing an ultraviolet light and we're scanning the patient's body and we see an area that fluoresces, that is a dried secretion that we are going to swab and put into the envelopes. We have fingernail scrapings. We have pulled head hairs. We do not do pulled head hairs in this area, but we still do have the envelope in there. Pubic hair combing and pubic hair pulling. We do perianal and anal swabs. We do vulvar or penile, we do vaginal swabs, and we do cervical swabs. So you can see that it can be very detailed on where exactly the contact would have occurred. And at any time, the patient can decline any of those steps. This is just a photo of the drug facilitated kit. And the drug facilitated kit we would be using if the patient feels as if they were more intoxicated than normal, if it was inappropriate to the amount that they had to drink. We would also use the drug facilitated if it was a memory lapse. We've had patients that would say to me, I was awake, I could see what was going on, but I couldn't move my arms. Those would be patients that we would be using the drug facilitated kit with. And at that point, we would be gathering urine and blood. Some other items that you would see in the room, on the left-hand side, we have the blood tubes. Below the blood tubes is ultraviolet light. And ultraviolet lights can look different in every facility. We have a couple that are flashlights. But what you might see in most of them is a Woods lamp, and the Woods lamp is always kept in the emergency department on an eye cart, basically. So any patients that come in to be seen for any eye injuries, the Woods lamp would be on there. So that is something that's always available in an emergency room. Next to the blood tubes, you'll see the speculum. A lot of times our patients have no idea what a speculum looks like, how it's going to be used. I will let them hold on to it, listen to the clicks so that they can know what's going on when I'm using that. Next to that is a handheld colposcope that we use at our facilities, and I know there's quite a few across the state that use that. And below that is a wig head. It's a styrofoam wig head. And what we use that for is for our domestic violence patients and our sexual assault patients who may have been strangled. We will take photographs of them showing us and demonstrating how they were strangled on our wig head and take photos. And then off to the side is another drying box type of supply that we use. It's if we did dried secretion to the left breast, we would then put those swabs into those areas on the body diagram that you can see there, and then that way we would know where those slides came from and swabs. So some of the other ways that we are communicating to facilities across the state is with the Telophase. So we want you to know that if you walk into a room and you see a nurse talking, to someone on the handheld colposcope, that it could be the telemedicine. And we're there basically to be able to walk any nurse through an exam from start to finish. Medications that we use. We want to make sure that antibiotics are given anytime after the assault. Ceftriaxone is actually Rocephin. It's an IM injection. Azithromycin is 1 gram orally, so it's about 4 pills that they get for that. And then the other one is Flagyl. It's 2 grams that we would be giving to the patient. So it's a lot of medications that they're receiving right at that time. We also will offer the morning after pill, and we always want to make sure that the patients are aware that the effectiveness decreases after about 72 hours. So we want to make sure that they are following up with their primary. We also do HIV testing and medications. In the hospital, we will give a 7-day supply and then a prescription for a 21-day. HIV testing should be done immediately. The medication can be started as soon as possible, up to 72 hours, and that is through the CDC. And again, you're going to want to start the medications as soon as possible. It's important for us to talk to the patient about the risk factors and the medication side effects. but we would never be the ones to tell the patient yes or no they should take the medications. It's definitely something that we want the patient to know all the information about, but give them the option to take it or not. The evidence and kit, a couple of things that I just wanted to throw out there is a lot of times my patients will call me a week later and say, oh, is there any way you can tell me what my kit showed? Because if it's positive, I want to go to law enforcement. And as many times as I explain to my patients that we do not test the evidence kits, the only people that test the evidence kits are the crime lab, and law enforcement is the only person who can take it there. So we cannot test anything from that kit. They may want to have it destroyed, and that is truly up to them if that's what they wish. If they want us to hold on to it, we can, and we will do that for 20 years. And I know that we're working with the state on trying to, find where the location may be to be holding them for the 20 years. Also, we're available for any questions that they have about the kits. We can reach out to law enforcement if we need to for the patient to find out where their kits are. But the most important thing that we try to explain to the patients is that we're not about the evidence. We are about our patients and making sure that our patients are medically okay. Confidentiality and medical records. We always want everybody to know that they can always obtain their legal record from our medical records department. We do not hand out our documentation to law enforcement because it is part of the hospital, and if they do need a legal certified copy, it does need to be subpoenaed, and they could get that through medical records. One of the things that we found out was we had a couple of patients that were working with their local college, and they were doing their peer, basically court time, I think it is, judicial process, yep. And when they were going through that, the college cannot subpoena a chart. So it was up to the patient to have to come to medical records to retrieve their chart. So it's just one thing that we always want people to, to know about. So with the Telophase, I did want to just throw in that we are working with St. Peter's Health Partners. We're using it for precepting. Nathan Latower, Ellis, Governor, Delaware Valley Hospital, Canton Potsdam. And then we have quite a few that are very close to signing on with us, which would be Saratoga, the Bassett facilities, Vassar, Columbia Memorial, Ellenville Regional, Geneva, Soldiers and Sailors, and Clifton Fine. There is a video that's on here that you can watch. It's, basically walks you through what it would look like for the telemedicine. And also our website is on there if you need that.
Do you want to hold on for a minute and
Sure.
answer a question?
Oh, sure.
So if a patient admits to using multiple drugs voluntarily, but does not feel they were drugged or overly inebriated during the event, should we still and always do drug-facilitated kits? Why and why not? And when do we use drug-facilitated and when not based on client's presenting story? We use drug-facilitated and when not used, not based on client's presenting story.
So the only time that I would use a drug-facilitated kit is if my patient is requesting one. And we do ask the patient about any drug use, because we let them know that, voluntarily, if drugs were used, it's going to show up on there. So we would, let the patient know that it would show up. We would document that the patient had, commented on using those drugs. But we don't always use the drug-facilitated kit. And the difficult part, too, with the drug-facilitated kit is because it's time-sensitive. Many of the medications are excreted within hours. So it's really, if they're coming in 72 hours, 96 hours later, it could be difficult to get any of those medications.
And just to chime in, we've seen over my 12 years of the program, I can't even count the number of situations where we've seen where, based on all of the description from the patient, it seems highly likely that there may have been a drug given, a predatory drug, without that patient's consent, but it was outside of that testing window. Mm-hmm. And even though, the kit was still collected, it came back negative.
Right.
And it's heartbreaking to see, but it's important. That's an important discussion as advocates for us to also be having with the patient if they are asking for that kit to be done. And just reinforcing that just because it comes back negative doesn't mean that that's an absolute negative.
Right.
Looks like there's another question here. What about a patient's inability to consent if and when they're under the influence, even with voluntary consumption of alcohol or drugs?
Sure. So we've been called in so many times into the emergency department, and when we get there, the patient is intoxicated to the point of where they can't stay awake. Their gait is not steady. They're unable to really answer questions. I would not consent the patient at that time. What we normally do is we will let the ER, know to call us when the patient is more alert, and we'll return, back to see the patient. When we consent our patient, we're acknowledging that the patient is steady gait, speech is not slurred, I can't even say it. Speech is not slurred, and they're alert and able to answer questions.
Is there still a long backlog of testing of kits in New York State now?
I don't know if there's a long backlog in New York State. I know working in the hospital, we have a different backlog than what, the
right.
kits that are out there that are being tested. In the hospital, we hold on to patients' kits that they did not want to have released. And I know that, we're holding on to quite a few of those types of evidence kits.
Did you want to chime in?
No, I just, my understanding is there is no backlog, and in part it's because we do, in New York State, the kits are not tested unless there is a law enforcement report made. So not every kit that's being collected is being tested.
Can a patient consent to sex while under the influence, even voluntarily?
That's a sticky legal question. I know there's a lot of legislation, and since we're not attorneys, I'm not going to necessarily say one way or the other. I have my own personal beliefs, and we as a program have our own beliefs. But I do know there is a lot of legislation being proposed right now to actually fix a little bit of a loophole that exists right now in the New York State Penal Code.
Yeah.
But if someone is given a predatory drug without their consent, then they are not able to consent to sexual activity. But currently under the New York State Penal Code, if they voluntarily become inebriated to the point where they are still able to function, then technically they are still able to consent unless they are deemed incapacitated. To the point where they can't stand up, they can't really, they're literally lying there. And it's been a real problem in the prosecution of these cases. So I know for us as a program, we really take the victim survivor's word. So if they feel as though they are victim and survivor of sexual assault in that circumstance, then we take them at that word, even though it may not be something that could be prosecuted.
Mm-hmm.
Looks like we had another question. What did you mean by HIV testing?
So when we see our patients in the emergency department, we actually do numerous cultures. A lot of facilities don't, it's one of the things across the state that I think we all kind of differ on. we do test for syphilis, gonorrhea, chlamydia, trichomonas, and the reasons why we do it is because we look at it as a community response. So we treat every patient with antibiotics and give them the antibiotics, but the testing, if they came back positive, it would not be from the sexual assault, but probably prior to. And we want to make sure that we're treating whoever this person has been with also. And it's good for the patient to know about their status prior to. And the HIV testing, we do a rapid test in the emergency department. It is a blood test. And what we are looking for to see if there's any antibodies. Because we are going to start the patient on medications, so we want to check to make sure that there is a negative prior to starting them on medication.
Okay. All right. There's going to be plenty more time at the end for other questions too, everyone.
And of course, I put any practice, any location, advocates are needed. I have been doing this since '97, and I can tell you that I have never not wanted a advocate in the room with me. It's so important. We need to work together as a team because it's all about our patients. And that is one of the things that, I think I would always fight for, is to make sure that I have an advocate in the room with me.
So there was another question. Whose role is it to discuss the patient's options, the advocate or the SAFE?
Well, if we're talking about the medical, I would really want the SAFE to be talking with them about that. I've had advocates that, can discuss it with the patients. They're actually medical personnel. But I really would like a medical person to be able to talk with them about medications, about risk factors. And it's not always just the SAFE nurse that's doing that. A lot of times the emergency room physician is in there doing it also.
And we've had situations where, a patient is unsure. They think they might want to have a forensic exam completed, so the forensic examiner is called in, and ultimately the patient decides and declines the exam, that it's not the right choice for them. So that's certainly an option as well, to be able to discuss it, or even maybe discuss over the phone, depending on the jurisdiction, because we recognize that what works for us here may not work for everyone across the state. Okay. So I'll jump in, and then again, there's going to be plenty of time throughout for more questions, because I recognize that as we talk through a little bit more of the advocate's role, there might be some additional questions that come up for Nancy. Before I start talking about and just giving some context for our program, I just want to reinforce that some of what Nancy just said. We are extremely fortunate, Nancy and myself and our programs, to work very collaboratively together and to have a very strong relationship. And even just to have forensic examiners who are trained with 24-hour coverage at our hospital facilities, we know is not the case across all of New York State. So I just want to let you all know that we're kind of speaking from a point of privilege as we talk about this, and that we recognize that the experience that some of you are having might look quite different. And, if later after this webinar you'd like to talk with us about brainstorming how to navigate what's happening for you locally, Nancy and I are always available. And I know that the Telophase option that is kind of spreading throughout New York State is a potential remedy for areas that don't have trained forensic examiners. So just to give you a little bit of context from about where I'm speaking from. So as I mentioned before, I'm the director of the Sexual Assault and Crime Victims Assistance Program with St. Peter's Health Partners. We consider ourselves to be a comprehensive crime victim assistance program. So we provide responsive, supportive services to all victims of all crimes. Obviously, today we're really specifically talking mostly about our response to sexual assault victims and survivors within the emergency department. And so for that context, just so you know, we are the certified rape crisis sexual assault program serving Rensselaer County, which is the county directly across from Albany County in New York State's capital region. And like many of you and the programs that you're representing, all of our services are free and confidential. And I won't talk about it, but we also have prevention education programs as well. And we do, I don't directly address it in any of the slides, but I wanted to mention that we are also very fortunate to have a very robust sexual assault response team. So we have a coordinator in our community who pulls together our multidisciplinary response, which usually mostly includes our healthcare and our advocates. But we have a really great team of folks in our community who really, truly are trying to work together as much as we can to serve survivors. And also to note, I use the term victim and survivor because I recognize that not all people who have experienced sexual assault are going to identify one way or the other, so I try to be inclusive with my language. So just to discuss a little bit about how our advocate response is set up, and again, I know it's going to look a little bit different across the state. We do have 24/7 coverage, like all of you, I'm sure. Our shifts are broken into two 12-hour shifts. So we have shifts running from 7 a.m. to 7 p.m. and 7 p.m. to 7 a.m. During the work week, we have our staff and interns take call from that 7 a.m. to 7 p.m., so they are responding in the same way that our volunteers do on the weekends. We also are using an online scheduling system called Team Up, where people are able to go in and actually schedule their time on call themselves, which is really nice. And we in our program have essentially a 3-deep backup system. And what that means is that while we have someone who is primary coverage for our hotline and our response services, we always have at least an additional 2 people who are backups to that person, because we recognize that there are some times where potentially an emergency happens to that person who's on primary coverage, or maybe they're already on a case and another one comes in. So we recognize that we need to have other people available to step in and help if need be. And if you want to learn more about how we've set that up, I can certainly share details with you outside of this webinar. So our on-call advocate who's answering our hotline is also the one who responds to the hospital. And again, I know that not every program is set up like that throughout the state, but the person who's covering our hotline is the one who is going in and providing that 24/7 coverage at the emergency department. We respond within 30 minutes, and we always go in to offer services in person, regardless of if a forensic exam is being performed. I know that there are some folks who might call and offer the service, or there are also some situations where the hospital says to the patient when they present, would you like an advocate to come in? We have found in our experience, and this is not to speak for all of you, but just in our experience, that very often a survivor who is in that situation is not going to feel like putting anyone else out. So if they're in and they're about to be seen in the ED and it's 2 a.m. on a Saturday night, and one of the ED nurses says, would you like an advocate to come in? Well, they might say no, not because they don't want it, but because they feel badly about saying, oh yeah, I need that person to get out of bed to come help me. So we always go in. We also consider that an opportunity to put a face, a friendly face, hopefully supportive face, with services. Because we recognize that while that survivor needs us right there in that moment, there might be time in the future where they also need us for other services for whatever reason. So we want to make sure that even if we don't stay with them for the exam because they don't want that we have provided them with information and as warm of a handoff and referral as we can. So this is just kind of an overview of how our kind of response protocol goes. So the call is received, whether it's from a patient or, in this case, the emergency department would actually be calling our hotline to report that they have a patient in the emergency department who needs to be seen. So currently the way we have it set up is that our hotline is answered initially by our switchboard operator with St. Peter's Health Partners. And they literally just answer the phone and then say, please hold, and they call the person who is on call. And when the person who is on call picks up their phone, the calls are directly connected. So again, in this case, then that volunteer advocate or staff or intern would be put on the phone with the emergency department. And at that point, we instruct them to request just some basic information about what is going on for the patient. So their age, just their first name, information about the situation, not details, but just so that we have a sense of what we're walking into. And also if they've been triaged yet, because we want to have a sense of where they're at. Not that that's going to affect our response time. We will go in right away anyway, but that is an opportunity just to see where things are at. And also at that point we can let the nurse or ED staff know what time we will arrive. Then when we get to the emergency department, within that 30 minutes, we let the unit secretary or the charge nurse know that we're there and our name and that we're the advocate. We have to really stress that we're the advocate and not the nurse, because I think that sometimes, at least in our system, and I'm guessing throughout the state, others have experienced this, there can be a lot of confusion around roles. So some people think, they might think, especially if they're newer or haven't received the right training, they might think that they've actually notified the forensic examiner, but it's the advocate, or vice versa, which Nancy and we've all experienced. So we really want to make sure that we're clear on our role. And then we ask where the patient is located, and then also we ask if a forensic examiner is being notified. We ask that, again, just to make sure that there's clarity on roles. There might be a case where a patient has not decided yet that they want to call the forensic examiner. And that's fine, but again, it's just an opportunity to clarify roles. And the other thing we always want to make sure is that we're not discussing confidential information in triage, in a waiting room, or in hallways. It's kind of easy for that to happen because emergency departments can be very busy, very crowded, and we want to make sure that we're all doing what we need to do to uphold our confidentiality and be respectful of our patient. At that point, we would go find the patient and introduce ourselves. And we're fortunate because we are part of the hospital system within which we work. We're very familiar with the departments in which we're responding. I would encourage all of you, if you are not embedded in a healthcare system, which I know most probably aren't, to really form some strong connections and make sure that there's a familiarity with the places that you're responding, so that you know where you're going if you're going out on a call. So we would go and introduce ourselves to the patient and explain who we are, that we're an advocate and we're there to provide support. In all likelihood, that patient has probably no idea about what their rights are, that they have the option to even have an advocate, and it might be somewhat of a foreign concept to them. So what we find is that we sometimes have to explain to them who we are and what we're there to do. And at that point, it's also a great opportunity to ensure that they have a copy of the Sexual Assault Victims Bill of Rights. We're going to talk about that in a little bit, but New York State in December of 2018, Governor Cuomo signed into law that there are certain rights that have to be upheld for sexual assault survivors, and every hospital is required to give sexual assault patients a copy of that Bill of Rights. So we want to make sure as advocates that they have that, not only because we want to be following the law and assisting our partners in following the law, but because it's really important that they know that those are their rights. And then, of course, we're going to ask them if they want us there. And most of the time, in my program's experience, they do want us to stay. There are certainly situations where it has been declined, which is absolutely fine. But as I mentioned before, that's an opportunity to at least make us, hopefully a somewhat positive, supportive connection, and give information, just hand over information that might come in handy or be useful in the future. I do want to just mention at this point, I know that this field is predominantly, or historically, has been predominantly staffed, and volunteers have predominantly been with people who identify as being women, but I feel like there is definitely a strong group of people who identify as male who are becoming important pieces of this movement, and it's so wonderful to see. And I know sometimes there are patients who may not feel comfortable with a male advocate, or vice versa. Maybe someone doesn't feel comfortable with a female identified advocate, and that's absolutely their right. We as a program would try to accommodate if someone is not comfortable with one of our male identified advocates, but we cannot absolutely guarantee it. But we would try everything we could to accommodate. And actually, I cannot speak highly enough of our folks who are identified as male on our team. They're wonderful and supportive. But I do know that that has been something that we've had to navigate as a program. So then at that point, if they do want us to stay, we're going to be there to provide active listening and support. We tend in our program not to ask details of the assault, especially if a forensic examiner is coming in. It's for a number of reasons, but really what we've seen happen most often is if a forensic examiner is coming in, they're already going to be asking those questions of the patient, and there's no need to ask the patient to explain what happened to them over and over and over again. A lot of the information that we need for our paperwork, which we'll talk about, is information that we can obtain during the interview process that they go through with the forensic examiner, if we're able to stay in the room, if that's something that the patient is comfortable with. So sometimes we wait until the forensic examiner arrives, if they're coming at all, or we may go ahead and start explaining some of the paperwork that we can complete as advocates. The biggest one really being Office of Victim Services claim applications. So I'm hoping that everyone is very familiar with those forms. We are fortunate in New York State that for survivors who come into the emergency department, we have a direct reimbursement program that basically allows for the survivor's health insurance to be completely bypassed in order to receive a forensic exam. What that means is that they essentially sign a consent for services on a piece of paperwork alongside the forensic examiner, and the hospital actually bills the Office of Victim Services directly for those services. So in many cases, the victim survivor will not see a bill. There are cases where there might be additional medical procedures or testing necessary that aren't covered, where someone might. And I don't know if you want to jump in.
The forensic reimbursement is offered to every single patient. And the patient does not need to have evidence collected. It could be just that we are going in, collecting, information for our chart on the patient. It does not have to have a evidence kit collected, does not need to have law enforcement. And one of the most important things is if this patient shows up to the emergency department and has a chief complaint of a sexual assault, they should be offered the forensic reimbursement. Whether or not a SAFE is even called in, an advocate is called in, it's the responsibility of the hospital to make sure that that patient is offered a forensic reimbursement. And there are many bills that do go out, so you really have to have a process that everybody who bills the patient is aware. So it could be the emergency room physician group, it could be EMS, it could be radiology. But the reimbursement that is sent back to the hospital is just for that emergency room visit and for the forensic exam. So it does not cover x-rays, sutures that are on top of that. So there's different ways that you can work with that, but I know at our facility, we basically do not send any bills out for anything.
And that is something that is another, I think, very important reason for you to have a strong relationship and be able to have a discussion with your local hospitals where you're responding, because you want to make sure that even if there is no forensic examiner program or service, that there is some kind of mechanism set up at the hospital that you're responding to offer that direct reimbursement as an option, because it is a mandate. It is a federal law. And that patient, if they are offered it and they accept it, it is against the law for them to be billed for those specific FRE services. And the Attorney General's office has actually been really holding accountable systems that are not following that law. So it's really a good opportunity for you to have a discussion with the hospital that you're working with, especially if there's no forensic examiner program, to ensure that there is a process set up for that. So I saw a question around this kind of next piece, which is an offer from the advocate to be present during the forensic exam. In our program, that offer comes from the advocate themselves, not from the forensic examiner. By that point, we've likely spent anywhere from 1 to 3, maybe even 4 hours with the patient, depending on if they needed any additional testing, how long the interview took with the forensic examiner. Admittedly also, how soon were we called in? Because it's not out of the realm of possibility for someone to present to the hospital with a chief complaint of, let's say, being assaulted, but then when they're being seen by a nurse in triage, admit that they actually were sexually assaulted. So they could have been at the hospital prior to disclosing that and prior to us even getting a call. So I would say most often folks want us to stay.
Right. And, we always, when we're doing our questions for our documentation, if there is a family member in the room, I don't ask the patient if they want the family member to stay. I ask the family member to leave because I don't want to put that onto the patient, feeling guilty for asking her mother to leave or whatever. So I don't put that onto the patient. But the majority of the time, the advocate and the patient kind of have a connection prior to me even getting to any of the questions.
And that's a great point Nancy brings up about additional people who might be present throughout the whole process. That's another great reason to have a strong relationship with the folks who are providing the service, if possible, because then you're able to really understand each other's cues to see if there might be a situation where you need to maybe assist. That I know I've been in circumstances on forensic exams where the parent really didn't want to leave the 17-year-old side, but really that was the appropriate thing to do. So I would try to help out by saying, hi, Mom, can I actually step out and talk with you for a couple minutes to give the nurse an opportunity to speak directly with the patient and maybe be able to reinforce for the patient at that point they have a right to decide who's in there, and actually we're going to encourage there to be a separation between the two of them, not because they're not a great support, but because there is information that's important to be shared that may not be shared if someone else is present in the room.
Right. And I've seen patients start to tell me something, and a family member or a friend goes, makes a gasping noise or makes a face, that patient stops talking because they know that that person can't handle what they need to say. So I don't want to put patients into that position. So, I do ask them to leave.
Right. And then if we are present during the exam, it's important to reassure in tandem with the forensic examiner of consent at every step in the process. And that's something that we as advocates can discuss with the patient prior to and during the exam and just reinforce. And, while the forensic examiner, I'm sure, is also going to be asking throughout, are you okay? Do you need to take a break? The advocate can also do that. And then also a really important piece to note is for the advocates never touch any part of the kit. That is really, really important. You do not want your DNA popping up in the kit somehow. So, try to stay as far away from that as possible. I did see someone ask a question around, basically they said, as an advocate, it's our job to make the client as comfortable as possible. What is your opinion on holding the client's hand if the client asks during the exam? I personally don't usually touch any of the patients for a number of reasons. First of all, I know in this situation you're asking, or you're mentioning they asked. I still don't want to make assumptions if that's something that they're comfortable with. And then also, again, I don't want my DNA getting all over. But I think that might be more of a personal preference, although, Nancy, I want to defer to you on the evidence piece.
Yeah, I mean, I know that sometimes when it comes time to do the speculum exam, the patients are nervous and scared.
Yeah.
And, I have heard them, ask the advocate, can you hold my hand? Or, and, I have seen that. And I think if that's what the patient, wants, then, that's all right from us. But, we try to just make the patient as comfortable as possible. We have blankets and, little stuffed animals and things for them to have, if that's what they want to hold on to. Sometimes when it comes to the physical part of the exam, they don't want anybody in the room.
Right.
It really differs. And that's one of the things, too. I don't know if anybody's ever seen the movie The Accused, but beginning of our SANE training, I show the 10-minute clip of the patient in the hospital. And I explain all the things that are wrong. And one of the things that's in there is the advocate standing down talking with the nurse while she's doing the speculum exam. And trust me, that would never happen in front of me because I'm the only person who needs to be looking at what I need to look at. The patient and the advocate are usually talking and looking at each other's face.
Right.
But if you ever get a chance to see that movie, like I said, it's everything that's wrong, with an exam. And I always like to open our SANE training class that way because I want them to know those are all things that you're not going to do.
And kind of jumping off of that, that's such a great point, Nancy. Positioning is really, really important, as well as for the forensic examiner, proper draping, and really that goes for any medical professional. But one thing that I was very fortunate to have the opportunity to do, this is years ago, like 12 years ago when I first started working in this field, I was able to actually pretend to be a patient as a pelvic model. And so I would spend like a whole day being a pelvic model, but not only having exams performed on me, but actually being interviewed by nurses who were going through this training. So I had an opportunity to really experience, as much as I could, what it feels like to be someone in that circumstance. Certainly, I'm not saying I understood it completely because I wasn't in that situation traumatized, but just to even have that understanding of what it's like to be sitting there on that table going through the process, I think has given me a really important perspective on what it might feel like to be that patient, and some of the sensitivities that we really need to be thinking about. And one thing that a lot of our team, my team does, is actually assist with some competency days that Nancy and her group organize. So we actually will pretend to be patients, not for the pelvic piece and the physical exam, but for the interview, and be able to share feedback with them about, ways that questions were asked and positive and also opportunities to improve things. But again, that also gives us an opportunity to sit there and pretend to be a patient being interviewed and gives us just a little glimpse as to what it might feel like to be on that end of things, and be able to really, I think, provide better services in the ED.
Sure.
So any opportunity that you might have to do that, I think, would be really helpful to all of us as advocates.
Exactly. And, competency days are so important because we always say you can't teach somebody bedside manner. It's something that somebody really has inside of them, and it's the way they ask a question. It's, their tone of voice. It's their body language. And we videotape, during our competency days so that the nurses can actually see their own facial expressions because they don't know what the actors are going to say back to them. And so we want to make sure that they're not, making any kind of facial gestures, when certain things are said to them.
Really quick, I just want to mention, because I see I jumped over it, and then I will go into a little bit more detail on some of these as well, is that there is, and I hope all of us know, but just to make sure, there is no requirement for the emergency department to notify law enforcement if a sexual assault patient presents. The only circumstance in which an emergency department has to notify law enforcement is if there's a weapon use.
If it's gunshots or stabbing.
Okay, so gunshots or stabbing, and then, of course, as mandated reporters to CPS. But I just want to be clear on that because our job as advocates is to make sure that we are helping to support victims, survivors, and what their choices are. And we don't want for them to feel as though we are not. And I think that's a really big consideration. A lot of what we end up doing with some folks is discussing the pros and cons of reporting to law enforcement or not, because I'd say about half of our patients report, generally, about half report and half choose not to at that time. And either is fine. It is absolutely their choice. It is their right to decide whatever they need to do for themselves. And then the last kind of step is to work as a team with the forensic examiner and hospital team, which could include social work team or discharge planner, to ensure that there is a safe discharge for that patient. We need to make sure that they're leaving and they're going to a place that is safe, and not back into a place that could potentially cause harm to the extent that we're able to. So I know there's a couple questions.
The movie that Nancy was referring to was The Accused, and that was the video that she shows at the beginning of the SANE training.
Of what not to do.
Yeah, exactly.
What not to do. So we'll go into a little bit more detail, but I'm also being cognizant of time and wanting to make sure we leave enough time at the end for questions. So some of this I might jump through a little bit quickly, in part because we've already discussed some of it. But these next few slides are really an overview of kind of our specific roles as rape crisis advocates. This is similar to the training that we actually offer to anyone who's coming on board as a staff member or a volunteer with our program. So it seems redundant, but our primary role is to serve as an advocate. And we're there to provide objective and knowledgeable intervention. This is, I think, one of the pieces that can be the most challenging for folks, especially folks who don't have a lot of prior experience in this field and might be doing volunteer work. A lot of people think, well, if I was in that situation, I would do this. And it's really hard, but we have to put our own feelings aside. And I'm sure all of us on this call know that. That doesn't mean that it makes it any easier. And we also need to remember that we're not that patient. We can't assume that we would feel one way if we were. And really our job is to be there and support them. We also need to help assess for their level of danger and need. We always ask about what kind of support they have. So if there are family or friends who they've already disclosed to, how that went and what kind of support they could get from them. Or if they haven't disclosed to anyone, talk about if there is anyone that they could, or if not, are there other supports that they could draw upon if they need it, such as 24-hour hotlines or follow-up counseling services. And then we always also talk about the need for follow-up assistance if necessary. And sometimes in that specific role, we might have to intercede if we see something or hear something that isn't in their best interest. But we always have to ask, is that going to help the victim or is it going to make it worse for them? And also, is it something that they're able to do for themselves? And, most often we've seen this where, they need something, maybe they're waiting for something, not from the forensic examiner, but maybe someone else in the emergency department, which can be a very busy place and lots going on. And so, they might need help with something, calling the charge nurse or getting some kind of assistance. And so I'm always going to want to have that conversation with someone. Is this something you feel comfortable doing yourself, or do you want my assistance with it? And make sure it's going to be in their best interest. And then our next piece of this role is to help facilitate their decision-making. And facilitate meaning we're going to weigh with them the pros and cons. We absolutely never make decisions for them. We all know that building someone back up and giving them control back in their lives after something as horrific as this happens is paramount to their healing process. So we're there to provide information to help them with their decision-making and maybe help make it less complicated. Or maybe in some cases, unfortunately, it makes it more complicated at that time, but at least they have all the information and really help them try to sort through it in that moment. And also help them with figuring out what are decisions that need to happen now and what are things that can come later. So for instance, do they have to tell their parents that night right then and there? They're anxious about it. They've already got a lot going on. Is that something that could wait till tomorrow or even the next day? Just as an example. And then once that victim survivor makes a decision about what they want to do, we are there to support them in carrying out that decision and whatever that looks like. So, if they do want to let a friend know what's going on, we can actually help them with making that phone call. We could make sure that there's a phone in the room that they could use or sit with them while they call from their personal cell phone, whatever's comfortable for them. We're also there to make sure they're aware of their rights. And so we mentioned this before, but there is now in New York State a sexual assault victim Bill of Rights. And sometimes it's important for us to remember that someone may not be in a state of mind where they can easily recognize their rights or a violation of their rights. When someone is traumatized, any of us, things can be very confusing and overwhelming. And so our job is to make sure that their rights are being respected and that also victim survivors are as clear as possible on what options they have and what rights they have. So I did include some more information about the Sexual Assault Victim Bill of Rights. It was signed into law by Governor Cuomo on December 21st, 2018. And the victim survivor can have the right to have this explained in more detail to them before the exam process. I have a link down here to it in case anyone needs assistance accessing it. But I do want to remind everyone that all hospitals are required to be giving this to every patient who presents with a chief complaint of sexual assault, and also law enforcement are required to be giving this out as well. So we just want to make sure that if we're working with someone in a hospital setting that they have received this piece of paper. So this is copied and pasted from the link that I gave you. So the general rights is that a victim survivor cannot be treated differently based on certain characteristics such as race, national origin, religion, sexual orientation, disability, age, source of payment, sex, gender identity, or gender expression. Then also their immigration status or national origin cannot affect their emergency care services, and they have the right to ask for an interpreter if it's hard for them to understand or speak English. That is very important. That is also something I would encourage all of us to know how to assist with access for. Every hospital is required to provide interpretation services if needed. So that is something that you want to make sure you're able to navigate at whatever hospital you are at. And then also minors under the age of 17 have certain rights to make their own decisions without a parent or legal guardian. So really we look at the age of, really 12 and up.
Yes, we look at usually 12 and up. A mature minor is able to consent to an exam as long as they can understand the consequences.
So then the next piece in the Bill of Rights is specifically to the speaking to a hospital emergency department rights. So they have the right to an advocate from the local rape crisis program who can stay with them during the exam. So that's also important for us to know, is that we can't just, say, all right, well, I guess things are fine and we're going to go. We need to make sure that as advocates, we are offering to stay with that patient for the entirety of their stay until they no longer want us there. That can mean a very, very long time, but that is really important. Also, survivors have, they can have an exam in any hospital emergency department to collect evidence and provide certain medical care related to the sexual assault at no cost to them. This is what we talked about before with the direct reimbursement option. If they don't have health insurance or they decline to use their health insurance, they can ask the hospital to bill the Office of Victim Services. Also, they can have medicine to prevent pregnancy and sexually transmitted infections, STIs, also known as STDs, for free. It does prevent certain STIs, but not all sexually transmitted diseases, just for clarity. I'm not a medical person, but I know that much. And then for HIV prevention, a 7-day pack of medicine can be started at the hospital. We are going to talk just a little bit about that later because that is very important in terms of follow-up if someone is taking the HIV medication. And then the last right is that they will be provided information on appropriate follow-up care, medical care. And then just so you have it, I know we're not talking about response within law enforcement or with law enforcement, but there are these additional rights that a sexual assault victim survivor has if they do report to law enforcement. Notably, I think it's important to know that they can have an advocate there with them during their interview with police or prosecution. And then also if they choose to report to police, their evidence should be tested within 100 days. And they can contact the police for information on the DNA match. Again, the forensic examiner program is not going to be able to give the details of the kit and the results of the kit. And then also that currently in New York State, we are now storing evidence for 20 years unless someone decides to release it or they specifically choose to destroy it. And again, all of that can be found at that link. I really would recommend that is something that all advocates have on them when they are responding in the hospital. So another piece of our role as a rape crisis advocate is to serve as an advocate and liaison between systems, which could include health, legal or criminal justice, family, college, etc. So oftentimes an advocate might be in the emergency department with someone who has numerous systems that they're working with or embedded in. So obviously they're already there dealing with a healthcare company and the emergency department. Maybe they choose to make a law enforcement report. And so then the police could be responding right there in the hospital and taking a report. Let's say they're also a college student. And in that case, they have an option of also making a report with their college. So sometimes as an advocate, we're trying to help them delineate, okay, who are they going to contact for what? Do they want to make a report here and not there, and really kind of tease out what options they have. And that can get very complex depending on who the victim survivor is. And I think it's important to know and remind ourselves that we are the one who is there for the patient. So even if they have family there, friends there who are there as supports, they might have their own opinions and their own interests. They may feel very strongly that person, the victim, should be making a police report, and that is what they should do. But it's important to remind the victim survivor that it is their choice. And also, as much as we can, inform that of their friend or family who feels so strongly about it. And also, we want to try to bridge the gap between systems in a sensitive way. And just going back to that idea of having a multidisciplinary team, I think that goes a long way to building strong relationships between colleagues and organizations who are going to be responding to these type of cases. If you know each other and you understand well the role that you each have to play in advance of the situation, you're going to be able to help navigate it and help navigate through that much more appropriately than if you don't have prior knowledge of that organization. So if I know, the folks who are responding and know their role, then we're already going to have a very good rapport going, and it's going to have less impact on the victim survivor depending on what choices they're making. We're also there to provide information, which is really important, and I think we sometimes forget that, is that we are there and we sometimes take for granted the amount of knowledge we have that we can share with that victim survivor. Now, of course, we don't want to overwhelm them, but we do know much more than the average person who is just kind of unfortunately thrown into that situation. And so it's important to remember that you, in that role, you can be an expert and you can share a lot of information with them that they may not have previously had. We also, in our program, we actually give a lot of written information because we know that it's very hard to retain everything when someone is going through this trauma. And so we actually have developed a manila folder that has a place for us to write all the pertinent information on it for that patient. So who the forensic examiner was, who their attending physician was, if there was law enforcement, who it was, the report was made with, the report number, all of that, so it's all in one spot. We also know that we aren't the expert in everything, and we also don't provide everything. So we need to be well informed about other potential referrals that we might need to assist the client with. So someone might come in and they may have been sexually assaulted by a family member or an intimate partner, and they may need to get to a shelter after this. It may not be safe for them to leave and be discharged home. My program, we don't offer a shelter. We do not have that capacity. So it's important for us to have strong relationships with the programs locally that do and know how to help access those services if a patient needs it, especially if it's 3 in the morning on a Friday night. So who are we going to call? How are we going to get them into a safe living situation or safe dwelling from discharge? And part of that is also making sure you have all the information right there with you. I know in this age of cell phones and smartphones, it's pretty easy to just kind of pull it up on your phone. But that's another point. You probably don't want to be on your phone when you're working with a victim survivor in that context. So as much as you can already have kind of tangibly right there is ideal. And also a familiarity with the agencies and the services that they offer that might be needed. We're also, as we mentioned, we're there to stay with the survivor through whatever point they want us there, and to offer comfort, companionship, reassurance. We need to take cues from them about what they need. And the other thing that I didn't write in here, but I always like to mention, is that if at some point during the exam process it's acceptable for them to have food or drink after a certain point, and we always ask the forensic examiner and would take their lead on it, that also can be something that could bring some comfort to that survivor, is, you know, a warm cup of coffee or a drink of water, or if they're hungry, something to eat. So, you know, while we want to stay with them, sometimes we might leave them briefly to go get them something that will bring them comfort. And then to offer emotional assistance and safety planning. So we use skills like active listening, validation, and other counseling techniques that we train everyone on. And we also are very keenly aware of the difference between emotional support and crisis counseling and mental health therapy. We are not there to do mental health therapy with them in that moment. We are just there to help them manage the crisis that they're in and get them to a safe place. And then if they do need additional mental health services or long-term counseling services, you know, to give them referrals for that in the future, whether it's within our own program or somewhere else. And then sometimes we do have to assist with safety planning. We often will do that in collaboration with the forensic examiner and the hospital social workers. You know, while we're kind of there as advocates and counselors, really the forensic examiner is also an advocate in their own way. They cannot discharge a patient if it's not safe.
Right. One of the ways that I always explain how a forensic nurse is an advocate, I always say I am an advocate for my patients during the time that they are with me in the emergency department. Once that patient leaves, I am not their advocate at that point. Yes, I do advocate for safe care. And we do ask suicide ideation questions to our patients at the end of the exam. And the reason that we do that is we did have a time where we had adolescents that had attempted suicide. And so we really felt that this is something we need to be addressing with our patients.
And one great, I know there's some discussion happening right now in the victim assistance world in New York State around screening protocols to use for suicide assessment. And I would highly recommend the Columbia, which is really the only well-researched and well-validated tool. I think that really we all are using some kind of modified version of the Columbia. There are some shorter versions.
Yeah.
So that's what I would highly recommend, and you could certainly reach out to Nancy and myself for more information about that.
Do you want to start reading some questions?
Yeah.
Okay.
And then really quickly, can I just mention paperwork? Just really quickly, I also think that paperwork is something that we often overlook. I think that, you know, we're so caught up in making sure that we're supportive of the client, but being supportive of the client now and really in the future also means doing paperwork correctly so that they don't have any additional stressors or burdens. The last thing we would want is to do paperwork incorrectly and then for someone to have to chase them later and cause additional, you know, burden to them to re-sign something that wasn't submitted correctly. So, okay.
Yeah, all right. I'm going to just scroll up. You missed a few?
Yeah. It was one about 96 hours.
Oh, I saw, yes.
So did we go back to, did we change it to 96 hours or to 120?
Right.
Did we change to 120 the rape or drug kit?
So, across New York State, it is done different at locations. 96 hours was what Department of Health had in their policy, and 120 is what's in the national policy. And according to the Department of Health on their website, they are now going along with the national policy. So at our location, we do the 120 hours.
Okay, so this webinar is being recorded, and it will be available for future viewing on our website. I am not sure about if the PowerPoint is going to be available, but you can access the webinar on the website, but we can share the PowerPoint.
Absolutely.
Okay.
Absolutely.
So you can email me and I can send you out the PowerPoint if you like. Can only hospital advocates be present when a victim is being interviewed, or can an HC paid advocate be present while the victim is being interviewed?
I guess that would depend upon who, what program you're using in your area.
And I'm sorry, Josie, it was an HC advocate? Is that what they said?
Hospital advocate be present when a victim is being interviewed, or can an agency paid advocate be present when a victim is being interviewed?
So really what matters the most is that it is a certified sexual assault program that the person is operating under the guidance of. So you have to go through at least 30-hour training with a local certified rape crisis program, and then become certified by the New York State Department of Health, and be operating under their guidance in that moment. So oftentimes we've seen situations where someone has gone through the training and they volunteer with a rape crisis program, but maybe they work for a college in a different capacity. They can't respond as a college employee to the hospital and put on their rape crisis hat in that moment and expect to have confidentiality and be present for the interview. They have to be operating as a person working with that rape crisis program in that moment, either a paid staff, an intern, or a volunteer.
Okay. Do you find that victims may not understand what the word advocate even means?
Yes.
Definitely.
And that's why I think it's helpful to give some examples of how we can be there to help support them. I think maybe the term support is almost easier to understand and really, comprehend. And again, give some examples about the ways that we might be able to assist them.
With rapid testing, if positive, they probably have the virus already. And if negative, what do you look for in order to offer PEP?
So if it was positive, yes, they had prior to. If negative, what we are looking at is liver function studies, because we want to make sure that they're able to tolerate the medications that we're going to put them onto.
And the other piece really quickly about PEP is that anyone who's interested in talking more can contact us. But for the advocates, that makes it especially important to do the paperwork correctly and to receive signed releases per your agency that you're working with, their guidelines, because there might be a need to submit an emergency award request through the New York State Office of Victim Services to assist with paying for those medications. They can be extremely costly, in the ballpark of anywhere from $2,000 to $4,000, and sometimes insurance will cover them, sometimes they won't. It just depends.
Can a nurse refuse to do a drug kit if the patient wants it?
I would say no. That if the patient is requesting it, then the nurse should be collecting that for the patient.
Okay. All right. Any last questions? I'm just going to make sure that we got them all. Okay. Well,
thank you. Thank you all so much, and thank you for having us, Josie. And just to reinforce again, Nancy and I are always happy to answer questions after the fact or brainstorm with you, based on your local community and what you're dealing with.
Yeah. And you have their contact information, and please take it down and feel free to have any questions for them. All right, great. Thank you. Have a great day, everybody. Thank you so much. Bye now.